Good morning. Welcome to the end of Orthopedics, Chapter 21.3, broadcasting from Johnston, where it's always sunny and warm. We start off this part of the chapter with external fixation of a Colles fracture. Colles fracture, remember, is when you're falling down the stairs or falling from rollerblading too fast, or not having a wrist brace on when you're rollerblading, but it's the thumb side of the distal radius, and it gets bent back like that and kind of stays like that until it gets fixated. External fixation is when they'll put in a device that puts screws in the outside and applies traction to realign the fracture. If it's internal fixation, it becomes implants with small fragment set, power equipment, etc. When you guys are doing orthopedic cases that are using fluoroscopy, if you can't get behind a lead shield, please wear lead. You don't want to get exposure to all that radiation. Also, make sure you have the C-arm available in the operating room early on. It gets hard to maneuver that around your sterile items when you have set up and then they're bringing it in. Sometimes it's good to bring it in ahead of time. A lot of the radiology techs and x-ray techs are pretty good about getting their equipment in the room early. But it's something to always continuously be thinking about for orthopedics, is to get the stuff in the room that you need early. And also, on that same note, make sure your prosthetics and your systems are on site and sterile, ready for use. You don't want to have a sterility issue in the middle of a case. Next fracture we're going to talk about is the ORIF of a hip fracture. These fractures are common in the elderly. They are common due to osteoporosis. Also, sometimes athletes really wear out their hips a lot, especially athletes that are in impact sports. Their hips tend to go down pretty easily. Special equipment, you're going to need a thing called a barrier drape. If you haven't seen this thing, it looks like a giant shower curtain. That's specific to hip fractures. The positioning can be very difficult. You're supine on a fracture table, and it looks like you're kind of floating out there. I have a picture of a fracture table coming up shortly. Fracture table is used so you can get that C-arm in there to view the full prosthetic and make sure everything's in place in the right spot. You're going to use DHS and DCS systems, dynamic hip screw, dynamic condylar screw systems. Those are specialized for hip fractures. There's your picture of the fracture table. So as you can see, doesn't look real pleasant to be on. You're going to be kind of floating out there in space. Total hip arthroplasty is usually the main indication is pain. And the pain doesn't get resolved by any other means. It says on the slide by conservative medical therapy, but even physical therapy, all these other things, it doesn't get resolved, so you need to replace that hip and stop the physical pain from occurring. Now, older patients are going to get cemented. If they're younger patients and they've just worn out the joint but they have healthy bone, they can get press-fit prostheses. Hips, most of the time, they are going to cement, though. Make sure when you are giving implants to a surgeon that you get a good read back. And my practice always was to have the circulator hold the box up and show the surgeon that that is the implant that they're requesting before you even open it. That way, it comes right down to them. They looked at it, they saw it, the box was open. When a surgeon takes a bite out of out of tissue, bone tissue with a rongeur, make sure that you have either a moist lap or a moist Raytech ready to grab the fragments out of the rongeur. It's very frustrating when they're trying to take a bunch of bites with that rongeur and you're not cleaning it out. There's still bone in there. Then they go to bite the bone and it's not going to bite properly because there's junk in the cups of that rongeur. I'll put some of the videos of these major procedures up so you can watch and understand the steps through the procedures. Some common instruments that are going to be used. The Charnley is a self-retaining retractor. Meyerding is also a self-retaining retractor. It's kind of like a wheat laner on steroids. There are lots of different depths of blades for Meyerdings that go from short to long. Also, there are Meyerdings that are angled, look like they're kind of bent in half, called angled Meyerdings. Your intramedullary reamers look like on the slide. It's just a big old drill bit. Can either have a T-handle or be hooked up to a power drill. Most of them power drill. Box osteotome is your cookie cutter. There's some rasps remount the femoral canal. They're going to put this triangular splint on the patient between their legs to immobilize them after the operation. It's an extremely uncomfortable thing, and if you haven't seen one, you may not see one. They sometimes don't put it on right away in the OR, but it keeps the joint immobilized, and it's a long recovery for these people. Intramedullary rodding. Femur is the largest bone in the body. We're going to repair the femoral shaft. Can be a very difficult procedure depending on the fracture. If there's a lot of pieces, if it's complicated from a spiral fracture to where the fracture is curved and challenging that way. Again, supine on the fracture table. Make sure your systems and prosthetics are present and sterile. You want to be not having an issue on a big case for sterility. You're going to use the AO nail system probably. Calibrated guide pin, guide rod if using cannulated nails. Cannulated nails, remember, are those, they have a hole in the center, so they go over a guide rod or a guide pin. Again, C-arm in the room early. These people get a splint for 5 to 7 days, crutch ambulation, and then the nail doesn't come out until the fracture's healed. So sometimes can be quite long, a couple years. There's your Trigen AO nail system. You can see the big long nails and guides. You can see that's how you can put a complicated fracture back together by driving those screws on through the different sides of it. Arthroscopy of the knee joint. As we have said several times, the patella is a sesamoid, or sometimes called sesamoid bone, but it's a sesamoid bone. The patella sits inside of the quadriceps tendon. Don't get that confused with the patellar tendon. Two big ligaments in the knee that stabilize the joint are the ACL and the PCL. ACL keeps the knee from sliding posterior on the tibia. Prevents hyperextension of the knee and limits the medial rotation. This is the ligament that gets injured most commonly. Torn ACL. The knee joint is cushioned by meniscus. There's lateral and medial menisci, and they are cartilage that gets sheared off or torn and then needs to be trimmed back. And the portion that's kind of floating there needs to be removed. Otherwise, it inhibits the movement of the knee. Arthroscopy can be performed for diagnostic purposes and also for removal of loose bodies, joint mice, shaving down patella and torn menisci, and repairing some of those ligaments. Make sure all of your video and endo equipment is in good working order before the case. Make sure you check your gas tanks. As I've told you guys in class, it's a pain in the rear to be changing gas tanks in the middle of a case while everybody's standing there waiting. There's your probe, which is also called a switching stick, and they'll probe around, feel for loose bodies, torn ligaments, things like that they're going to fix later. That probe is kind of part of the diagnosis side of it. Arthroscopic biters, those are just different biters that bite chunks of meniscus or torn ligament off. These ACL tears, they're very common for sports and athletic people, and skiing is really your knees take a real hard beating in skiing, so that can be a place where you get these torn ACLs. The Lachman test is a test for the stability of the knee, and the details are explained on that slide. ACL repair, we're going to use either an autograft or an allograft. Synthetic is rarely ever used. Most patients, it's going to be an autograft. It'll be either patellar tendon, sometimes hamstring, sometimes quadriceps tendon. It's just kind of a surgeon preference thing as to what is used, but most often it's going to be an autograft. An allograft, as we remember from class, is from a cadaver. Some special equipment, we're going to put a tourniquet on just like we do in class. We're going to use power equipment, bone screws and staples, spiked washers. There's some little tricks for tacking those ligaments on so you have some fixation devices. And those would be the bone screws with the spiked washers. And the interference screws are bioabsorbable screws. Prognosis, 8-week period, patient uses crutches, and they continuously increase your range of motion. You're going to do some physical therapy with straight leg raises, toe raises, squats, and by 2 weeks post-op you should have 0 degrees of extension and 90 degrees of flexion by 4 weeks. Now that's going to be more than likely with pain, because that is going to be very sore after your surgery. We move on to above the knee amputation. These, I'll show you some of the instruments coming up. The listed amputation knife is very, very sharp. Be extremely careful and cautious with it. If it just touches you, it's going to cut you. It's sharp on both sides, so the blade, you'll see in the picture, has a sharpened edge all the way up and down both sides. The jiggly saw is a saw that it's like a wire that hooks onto 2 hooks, and they pull it back and forth, and it saws through the bone. Satterley bone saw looks like a miter saw, like a hand miter saw, just saws back and forth that way. And there's some rasps to smooth the end of the bone over. You don't want sharp edges of the bone. Patients are going to feel that against their stump, and it's going to cause a lot of pain. You can transport the knee to pathology in a Mayo stand cover. Position is supine. These cases are done rather quickly. They bleed a lot. There are, as I said in class, there are some religious ramifications to amputations. There are some cultures that believe the leg needs to go back to the patient when they pass. So make sure you're aware of what's going on that way. We talked about phantom limb syndrome and phantom pains. Stumps are protected and are usually healed 3 to 4 weeks. There is a kind of a long, hard curve for getting used to the prosthetics that they get put in, because they're, as you can imagine, your leg gets cut off and you have a stump of bone there that's pushing on something on the pad that's underneath it. That's the part that fits into the prosthesis. That's going to be sore for a while trying to get used to that prosthetic. So there's your Liston amputation knife. It's actually, it looks small in the picture, it's long. It's a big long thing, it's longer than that even, it's about yay long. And they use a sawing technique with it, but it just rifles right through all the muscle and vasculature. There's your giggly sound blade. You can't see the blade in the picture very well, but it's like a big coiled wire. Satterley bone saw, like I said, looks a lot like a miter saw. The rasps are they're just like big files is what they are. You file off the bone so it's smooth. Below the knee amps are just like above the knee amps. They're going to be a little more cautious about that stump because now you're creating an articulating joint into that stump. So, and these are very common to have revisions on that stump because, as you can imagine, with keeping the knee in there, you're going to have a lot more movement and they're going to put a lot more stress on that stump so they can wear it out a little bit. Total knees. Total knee arthroplasties are the most difficult joints to replace, and that is because, like the slide shows, there's 3 different planes that there is movement occurring in: abduction and adduction, flexion and extension, and rotation. So a lot of challenges there to keep the motion proper. We have to preserve all the ligaments. Again, total joint, they're gonna wear space suits, look like spacemen, and that's pretty common in most places for total joints. Where I work, nobody ever wore them, but it's pretty common here, I guess. 3 different kinds of compartmental knee implants: uni, bi, and tri, depending on how much of the knee we're replacing. You need 2 Mayo stand setups. One for your instruments, one for power. And maybe your specialty stuff that you have. There's the space suits. Looks like they're operating in outer space. They're only doing that to prevent surgical site infections. There's your cement mixer. Remember, if you're pregnant, get out of the room. Cement smells and is toxic to the liver. Triple arthrodesis is the ankle joint. And this is mostly done for foot deformities. Club foot, when arthritis attacks the joint and snarls it all up, you have to do something to regain mobility in that foot. So, and as the slide shows, contraindicated in kids 10 to 12 years because it limits their foot growth, and obviously if we do something at that point, it's probably going to fail. Special equipment, we're going to have AO compression plates, bone grafts, power saw and drill. Most orthopedic cases you're going to use power equipment, unless it's just a soft tissue thing. Some of the special instruments for triple arthrodesis: Prego periosteal elevator and an Inga lamina spreader. Achilles tendon is the strongest, thickest tendon in the body, approximately 6 inches long, usually ruptured by trauma, and it can be a partial or total tear. This is very common in people that are my age because they've been kind of athletic their whole life, and then the body ages and those tendons lose elasticity and the blood supply to them starts to get compromised, and then old Johnny wants to go out and play soccer with the kids, and pow, pops his Achilles tendon. Big, long physical therapy and recovery. I'll show you the tendon pulling forceps. Think about that thing, yanking your tendon back up. Ouch. Bunionectomy, Hallis valgus. bony exostosis located on the medial side of the first metatarsal head of the great toe. Some of you guys have had these procedures, kind of a painful recovery. Remember, we're biting off a big chunk of bone that's on there and realigning that great toe. There are some different types, Aiken Chevron, McKeever, Keller, McBride. All those are different techniques of doing the surgery. They're all quite similar, and they all have the same outcome. We're biting off that bunion and we're realigning the great toe. We're going to use a ton of knife blades in these procedures. Lots and lots of knife blades, cutting back that stuff off of the bone, all that overgrowth. Really common for women to have these. If you think about the kind of shoes that women like to wear, causes them to have that lateral deviation. Also, having flat feet is a common thing to cause this. That's the end of orthopedics. Hope you guys enjoy the rest of the weekend, and we'll see you Monday.